Yeah, yeah, yeah. Very good evening, respected doctors, and myself, Praveen, RSM Sanpharma. Herewith, I'm welcoming all more respected Dr. Venkatraman Reddy sir, moderator, speaker, and coordinator moderator, Dr. JP Reddy sir, Dr. PB Kameshwaran sir, Dr. Chaudhary sir, to this 15th webinar of AP AOI branch. Sanpharma always takes pride and privilege to serving doctors fraternity in terms of providing them academic backup and actively participates in all terms of academic activities, conferences, and seminars. It's our pleasure. Pleasure, sir. With this, I'll hand over session to Dr. Kameshwaran, sir. Sir, please, over to you.
Okay. Thank you very much, Mr. Praveen and Sun Pharma. This is a very good initiative for medical education and imparting knowledge to all our colleagues. I really appreciate the initiative taken by the Sun Pharma. We are very thankful to you, and I am very happy to introduce my friend and Professor Dr. Venkatraman Reddy garu for this meet. He is a renowned ENT surgeon. When we were combined Andhra Pradesh together, he worked in various capacities in the Koti ENT hospital. He was retired and now he is working with the Bhaskar Medical College and Ma ENT Hospital. He is a very good academician and he is very interested in conducting meetings and workshops. We have attended several of his workshops in Koti ENT Hospital when he was the professor there. I welcome him and I request him, and he was one of the most important key personalities in Asia Oceanic Conference, which was held in Hyderabad. So I am very happy to tell about it. So let us start the meeting. Sir, welcome, sir. Venkatraman Reddy garu, please start your lecture, sir.
Thank you, Kameshwar garu. At the outset, I like Sun Pharma for conducting this meeting, Zoom meeting, and I thank my colleagues, Dr. Kameshwar Rao, Dr. Jayaprakash Reddy, who are the prominent ENT surgeons in the Andhra and the Rayalaseema. And I thank the Sun Pharma, the Praveen, and their team for organizing this meet. So can I enlarge this?
Yes, sir, please.
Is it visible now? Our pictures are more visible.
Just click on the slide, sir. It will be enlarged.
No? Click on the slide. No, it is coming. But our pictures are obstructing. Our pictures are visible there?
Yes, sir, it's visible.
I think you can remove our pictures.
Sir, that pictures nobody will see. You will see.
Okay.
So you can keep that in the speakers mode, side by side. Go to view.
Okay. Am I audible?
Yeah,
Yes,
you're
sir.
audible. Then go for this one, the slideshow.
Slide share is there.
Slideshow.
Slideshow, it is slideshow only. Are you not getting my slide? First slide?
I'm getting, but not the slideshow mode.
Not in the slideshow mode.
No problem. You can go ahead, sir. Still go ahead.
I can go ahead?
Yes, please.
Yeah, today I would like to talk on the imaging techniques that are available. Imaging techniques that are available to every ENT surgeon, practicing ENT surgeon, and their impact on the sinus surgery and also the skull-based surgery, the various lesions. Because the junior ENT surgeon, they don't know what type of image they have to go in a given case. Suppose a case comes, a sinonasal inflammatory disease comes, a tumor comes, a suspected inverted papilloma, suspected JNA, or CSF leak, or any tumor pathology, or whatever pathology, a sinonasal inflammatory problems, non-inflammatory problems, polypoidal lesions, non-polypoidal lesions, or any tumors, if they come, they just have a blank face initially, especially the juniors, not experienced surgeons, as to go for which modality of the imaging technique of a sinus evaluation as well as a skull-based evaluation. I think you know all these things, but these plain X-rays have almost become completely obsolete nowadays in the practice. For the past 10 to 15 years, we are all practicing. So the computed tomograms, the CT scan and MRI are the gold standard for the evaluation. The simple reason why the X-rays are become obsolete is that they are overlapping and the larger sinuses only evaluated, and you cannot assess any ethmoidal pre-chambers assessment or any congenital anomalies.
Sir, sorry to interrupt, sir.
Yes.
We are seeing the only first slide. We are not seeing the third one.
No, I am changing. No.
No. That is why you have to you close this and go to again screen share.
That's better,
Can I see the end show now? I stopped sharing.
But still we see your slide.
Yeah. Stop. Shall I stop share?
Yeah, please.
Yeah, stop share.
And now you share again.
Share my screen. Speaker sound. Green button share screen I shared, and the slideshow, PowerPoint slideshow.
Sir, first you have to open your presentation on the desktop.
No, on the desktop it is there. I minimized it.
You keep that.
Hello? Hello?
Yes, sir.
Share screen. Now I'm sharing the screen.
Yeah, after clicking share screen, please select the slide, sir. On that slide, please click.
I think I have to log in again, open up and log in again.
No need, sir. No need.
No need?
Just share after. No need, sir. Just open the slide first and click on the window of Zoom.
I can't see the slide anymore now.
Okay, I think it is closed. Just please open the slides, sir, first. Yeah.
Open the slides means I have to go to 1 minute.
Yeah, minimize this screen.
Minimize.
Now open the slides.
I'll
Sir.
open the PowerPoint.
Yeah, please.
I'll open the PowerPoint again.
Yeah. Now just open Zoom window.
Yeah, now I minimize this.
No need to minimize, sir. Just like that, you can click on Zoom window.
Now are you able to see my slide?
No, sir, not yet.
No. Minimize.
Share screen once again, please, sir.
Share screen I'm not able to see again. Huh? Hello?
Sir, first you have to open your presentation.
I minimized it. Share screen now.
Now you share the screen. Now.
I clicked on the share screen, and now I got our PowerPoint visible now.
No, we are unable to see your presentation.
PowerPoint, 1 minute.
Technical people, please.
Sarvin, are you there?
Sir, you log out and then again log in, sir.
Log out.
You close your Zoom and then again you open.
Leave the meeting.
Yeah, leave the meeting. Yeah, now again. Yes, sir. Now you.
Share the screen.
Yes, sir.
I'm clicking on share the screen. My PowerPoint is there on the minimum.
Now
So-
you.
Is it visible now? No.
Sir, how many MB is your this one, sir?
No, it has to come. Is it? Has it came?
Now it's coming. Yes.
Now it's visible, sir. Yeah.
Okay.
Now you
No,
go
audible?
to slideshow.
Yeah, slideshow. Slideshow. Yeah. New slide share. Slideshow. Where
Here,
is
down, so downwards.
the?
Oh, cup is there, no? You just yes,
I opened it, huh?
yes.
I enlarge it. Are you able to see?
Sir, you come by. Now we are seeing the first slide.
Yeah, first slide.
Now you come.
I'll change it to second slide.
Now we are seeing on the first slide.
First slide only.
See, because when you select the PowerPoint presentation, there are two options. Technical people or support. See, we are unable to.
I stop sharing. Again, I am opening. Share. Now, share screen button I click. Next. Screen, first option. Either screen first option here, neither. Share around optimize share. Slide share has declining. See, you have participants, you have chat, share screen, record, reactions, apps. Share screen is
Sir, green is there. Share screen.
yeah,
Click on that.
green I already clicked.
Then we are not getting the slide.
But if I click, you are getting slide.
Sir, what is the how much MB this got, sir, presentation?
I don't have clear idea.
You can send it to me. I can run the slides.
How?
Email.
Email, I have to concise it and send it to email, no?
Then we are not getting the share screen, no?
No, share screen I clicked. I am able to see here the display, but how to actually make there to share?
Yeah, now it has come. Yes.
Huh?
Now it's visible, sir. Yes.
Now it has come, sir. Now you go to second slide.
Second slide now. Second slide, I am not.
Yes.
Yes. Now, okay.
Now
Go
it's
ahead,
coming.
sir.
You got
Go
second
ahead.
slide?
Yes, sir.
Yes.
Third?
Yes.
Okay. Is the slide completely visible?
Yes.
Yes. Yeah. Can I start now?
Yes, sir, please.
Yeah. I think now the CT-PNS, as an initial investigation, the CT scan of the paranasal sinuses is the gold standard because it displays the bone and soft tissue and air simultaneously. That's the reason why it is gold standard. So it can display the normal anatomy and also its variations. That's the reason why our first initial investigation is the CT scan. And CT scan not only identifies the site of obstruction, but also gives the extent of pathology and the disease. And it can also give the road map for the endoscopic surgeon. Not only that, it actually decides whether you can go for external approach or endoscopic approach. I think this is all well known. And look at this. See, if you do a diagnostic endoscopy, it will not give an idea, but the CT scan gives straight away the diagnosis. For example, the dentigerous cyst and fibrous dysplasia. So even if you do diagnostic endoscopy, take clinical examination, nothing. So the CT scan straight away gives the diagnosis. See, the multiplanar is the choice for obvious reasons. Then how to read a CT scan? Different the surgeons will read differently, but how I read for guidance for juniors is first orient yourself right and left, and then anterior and posterior, and read the septum, which is in the midline, and read the lamina papyracea, which is the lateral boundary of the sinuses first. Then define the skull base and anterior ethmoidal artery, optic nerve, and ICA, because they are the vital structures, and have the picture in your mind. And the best would be, we can recommend is the DICOM software viewer, which can be downloaded from the net, and you can actually make use of this so that you can actually run through the CT scan very nicely. For example, this is a navigation system with the DICOM software viewer and navigation system. You can see the tracker is in the posterior ethmoidal cell over the optic nerve, the descent optic nerve in the posterior ethmoidal cell. And you can see this is the kerotico-optic groove in the sphenoid sinus. The tracker is easily visible here. And the DICOM software also helps not only in navigation system, but also you can actually identify the structure. For example, here the tracker you can see here, we are viewing the CT scan with the DICOM software viewer, and the cursor now here is in the tracker is in the anterior wall of the sphenoid. Now, the skull base type, the Kiro is a Croatian physician. It's very funny to know that the Croatian physician has actually described the skull base type, the skull base type 1, 2, and 3, as people are aware, depending upon the depth of olfactory fossa. 1 to 3 mm, 4 to 7 mm, and 8 to 16 mm are the type 1, 2, and 3. The type 1 is the most common type in the clinical occurrence for our knife, and type 3 is very dangerous type. If you can assess the type 3, wherein the skull base is very low, and actually endoscopic surgeon can cause injury to the skull base. So whenever you are assessing, either you assess the depth of olfactory fossa or the height of lamina lateralis. This is a lamina fibrosa, and this is a lamina lateralis. We can see the height of lamina lateralis. Depending upon height of lamina lateralis and the depth of the olfactory fossa, when height is increased, the depth will be more, so that you are more vulnerable in the endoscopic sinus surgery to injure the skull base. So that's the basis for this Kuros type of classification, wherein the type 3 constitutes most dangerous type, and luckily in the literature it is only 5 to 10%. The type 1 is the commonest, which constitutes about 70%, and nearly 20 to 25% are type 2. So this is a boy whom I operated almost 15 years ago with a skull base type 3 with a nasal polyposis. On the right side, you can see the precaution in this particular case is you are not supposed to use the instruments which can pull the polyps, or you have to use, and debrider also should be used with very, very caution. So your through biting forceps are more useful, and you must take the help of navigation in these cases if required, not to injure the skull base. Now, if you can see here, this is the intersinus septal cell. You can see the right frontal sinus, the left frontal sinus. This is the intersinus septal cell, which opens into one of the frontal sinuses. Some people call this as a third frontal sinus. So importance is, so when it is diseased, how you access this particular cell. So all the cells in the frontal recess, they are all frontal cells. The frontal recess cells are all frontal cells. Depending upon the number and situation, the frontal cell can be type 1, where one single cell above the Agarnese cell and below the frontal sinus are type 1, and a tier of cells, the type 2, and the type 3 is when a cell extends 50% of the height of the frontal sinus, into the frontal sinus, it is type 3, and type 4 is completely isolated cell. So these are all devised by Kuhn from Germany. They're called, that's the reason why it's called Kuhn 1, Kuhn 2, and Kuhn 3. So these situations, the frontal side, the impact of the imaging is so much that there is a difficulty in operating in type 3 and type 4 cells, which require angle telescopes and the curved instrumentation in the frontal sinus. So often these things can warrant navigation sometimes. Otherwise, if you are experienced, you can carry it with the frontal sinus instruments, which are curved, and angle telescope like 70 degree is a must in tackling these situations. So, for example, the impact of this particular the CT scan of sinonasal, here is a case of chronic rhinosinusitis, is one of my patients, where you can see here the cell, this is the agarnase cell, and this is the frontal bulla cell. So here, the reason why I kept this particular CT scan is these agarnase cell have to be dissected from posterior to anterior. That is, if you have to insinuate the J curate posterior to the cell and curate it anteriorly. So this cell you cannot dissect that way. You have to dissect from anterior to posterior, not to injure the skull base, right? And this depiction is because this site of configuration should be handled very delicately with again the angle telescopes. So these cells are vital for the obstruction of the frontal outflow. Now, the hypoplastic maxillary sinus, the CT scan, when it shows, it is so much of importance, especially for juniors, to do a middle meatal antrostomy and uncinectomy, wherein, you see, if you draw a line from medial orbital wall vertically, the medial wall of the maxillary sinus is more lateral. When the situation is called the hypoplastic maxillary sinus, the presence of medial wall of the maxillary sinus is lateral to the line drawn by the medial orbital wall. So the maxillary sinus, normally it is pyramidal in shape. When there is hypoplastic situation, it assumes oval in shape, and the pneumatization is absent below the level of the nasal floor. So these kind of situation, so when there is hypoplastic maxillary sinus, during uncinectomy, you need to use an angle telescope like 30 degree or 45 degree or 70 degree, and use a ball probe gently or a J curate, and not to enter the orbit, because to enter the orbit, it's just a millimeter or two are required to enter the orbit. So this is such when my hypoplastic maxillary sinus is there, one must be very careful not to enter the orbit. Then this is another kind of situation where you can see that there is a septation of the maxillary sinus. Suppose there is a disease here and here, you see that when you open this maxillary sinus and finish your job. No, you need to actually break the septa and make into one of the maxillary sinus. The halar cell, I think everybody know it, is a migratory cell with a medial orbital wall. Then the supraorbital cell again has a very good impact, especially during sinus surgery. If there is a supraorbital cell, it mimics the frontal sinus. See, so when supraorbital cell is expected, it has to be diagnosed both, because we cannot diagnose the presence of supraorbital cell only in the coronal cut. You need to have an axial cut as well. Look at this. These are the frontal sinuses. These are the supraorbital cell. When supraorbital cell is there, there is a large suprabular recess, and the anterior artery is supposed to lie more posteriorly in the skull base. As you all are aware, the anterior artery is just at the attachment of the superior attachment of the bulla, or a millimeter or two posterior to the attachment of the bulla at the skull base. But in a supraorbital situation, wherein the anterior artery goes more posteriorly, and it also may be decent. So one need to be very careful in supraorbital situation, wherein you find the anterior artery more posterior. That's the importance of this particular slide. Then Unodi, as described by Stamberger, who is the father of modern endoscopic sinus surgery, as any cell which is 1.5 centimeters beyond the anterior wall of the sphenoid sinus. That was the actually definition given by Stamberger, which is no more applicable in our clinical setting, in our clinical practice. And we also said any cell which is 0.5 millimeters away from the optic nerve is called Unodi cell. So, depending upon the attachment with the annulus of Zinn and visible bulge or non-visible bulge, the optic nerve, we divided into the three categories: the indirect Unodi, where the posterior ethmoidal cell ends anterior to the annulus of the Zinn. The direct Unodi is one where the posterior ethmoid opens beyond the annulus of Zinn and there is no visible bulge. If there is a visible bulge and the posterior ethmoidal cell is going beyond the annulus of Zinn, then it is called direct Unodi positive. So this is displayed in the textbook of Stamberger, wherein you are liable to injure the direct Unodi positive situation. It is dangerous to injure the optic nerve. So these are some pictures. You can see the Unodi cell is best identified in the coronal cuts. You can see the horizontal septation. You see the horizontal septation here. These are the Unodi situation where the optic nerve is popping into Unodi cell in its lateral wall of the Unodi. Here also the optic nerve is popping in from the roof on the left side. On the right side, it is from the lateral wall. It is completely dehiscent. Now, sphenoid situation, I think we have three different types of sphenoid: the conchal, the pre-cellular, and cellular situation. This is a diagrammatic representation. And this sphenoid sinus is completely a variable. You can see the dehiscent optic nerves in the root of the sphenoid. And here, the through-cut instruments are very important because the intersphenoid septum is ending over the carotid. This is a carotid artery. It is ending over the carotid. And you need to use the through-cut biting instruments. And no twisting or avulsion is required here, because if you twist it and avulse it, you may injure the carotid artery. Then an interesting classification of the types of the optic nerve anatomical variation is very important. This is from the Radiological Journal, International Radiological Journal, wherein the Delano et al. Has actually classified the optic nerve anatomical variations. Optic nerve anatomical variation in relation to the sphenoid sinus and the posterior ethmoidal cell. They divided into type 1, which is a commonest situation in clinical practice, wherein the optic nerve, it runs and courses immediately above the sphenoid sinus, but no indentation into the sphenoid sinus. The type 2 are, there is indentation, but it is not dehiscent, and it has no relation with the posterior ethmoidal cell. Both type 1 and type 2 has no relation with the posterior ethmoidal cell. The type 1 is commonest situation where there is no dehiscence. The type 2 is there is the dehiscence. Then type 3 optic nerve is the optic nerve which runs as a dehiscent optic nerve, and its circumference is more than 50% of the circumference of optic nerve is in contact with the air in the sphenoid sinus. It is surrounded by air in the sphenoid sinus. Type 4, but still it has no relation with the posterior ethmoidal cell. The type 4, I think this is more practical classification. Type 4 optic nerve is, it has intimate relationship with the not only the sphenoid but also posterior ethmoid. This is the very dangerous situation for endoscopic sinus surgeon. I think anything you can stop anywhere. Yeah. Am I audible, please? Hello? Hello?
Yes, sir. Audible, sir. Venkatram Reddy garu, please proceed.
Okay.
You are very much audible.
Yeah.
Very clear.
This is a very interesting CT scan where you can see the agenesis of the sphenoid, non-pneumatization and agenesis of the sphenoid. In this situation, there is no way you can go in for the transsphenoidal skull base surgery. So pituitary or clival chordomas, you cannot do, or petroclival chordomas, you cannot enter into the sphenoid sinus with such a anematized, non-nematized agenesis of the sphenoid sinus. This is the importance. So there is a contraindication for a trans sphenoidal pituitary surgery in such a CT scan situation. So the impact is such a, so they need to go for external approaches. Another, a word of cone beam CT. A cone beam CT, now it is available in many metros. So it is a very compact version, very safe version, and faster version of the CT scan, which can give 3D images. It has almost 1/100th of the exposure of normal CT scan. What normal CT scan has a radiation exposure, 1/100th of it, of a regular CT scan. And it takes less than a minute to get nearly hundreds of images. So cone beam CT is now available in many metros, and it is come. Then coming to most important part of today's discussion is the imaging of the PNS. We have discussed some of the interesting situations, the CT scan situations, but now we enter into the MRI and compare the clinical situations which a regular ENT practitioner will get in their practice, whether to go for a CT scan or MRI or both, and what is the advantage, what is the disadvantage of various modalities of imaging of the sinuses as well as skull-based situations. MRI, basically now it is assuming a lot of importance. Probably the next decade, MRI will rule in the imaging of the anti-skull base. So what are the situations where you can go for MRI? So these are the common situations in our clinical practice where MRI is definitely indicated. For example, if you have any diagnostic dilemma in the CT scan, if you have a diagnostic dilemma in the CT scan, you can go in for an MRI to evaluate yourself, to analyze yourself as what I am dealing with. Then a disease going beyond the confines of the sinuses. For example, it is going into the orbit or skull base, then you can go for MRI. Then all sinonasal tumors, irrespective of the age. If there is a tumor-like situation, yes, you have to go for MRI. If all immune-compromised hosts, the immune-compromised hosts, they have situations like invasive sinusitis, which you have to rule out, wherein MRI is more useful. Then certain complications, post-op complications. We have a post-op complications like the orbital complication. You have done a sinus surgery, there is orbital invasion or optic nerve injury or skull base injury with the CSF, then definitely MRI is useful. So these are the broad indications. Am I audible, please?
Yes,
Hello?
sir. Venkatram Reddy garu, audible.
Yeah. The slides are visible, no?
Yeah, visible.
Okay. Then, so now I go into common situations wherein what is the role of CT scan, what is the role of MRI in such a common situations in our day-to-day practice. First, we'll start with the antroconal polyp. For antroconal polyp, the preferred method of the imaging is the CT scan. CT scan is usually the preferred method. Suppose you have a diagnostic dilemma in the antroconal polyp, certainly you can go for MRI. But CT scan by and large is the most important and key investigation for the diagnosis of antroconal polyp. As you can see here, the CT scan above is the CT scan and below is the MRI for a AC polyp of one of my cases, wherein you can see the smooth lobulated enlargements. You can see the lobulations, the smooth enlargement with no bone destruction, and there is a wide os, that is the posterior fontanelle is very much widened. You can see accessory ostium is very much widened. This is a classical picture. If you take MRI in all antroconal polyp, the T1 weighted image will give the low or intermediate signal, and T2 image, the T2 weighted image gives a homogeneous signal. So this is usually the case. So depending upon the water content of the the antroconal polyp, you get a T2 weighted image as a high homogeneous signal, and T1 weighted image is a low intermediate image. In a case of diagnostic dilemma, whether I am dealing with the anthropoid polyp or something else, you can actually take the MRI as an added modality, and you can actually differentiate how the T1 is how is the T2 weighted image. So these are the classical the appearances in a case of anthropoid polyp. Next, we go for inverted papilloma. The inverted papilloma, the CT scan generally shows a ballooning opacity with hyperostosis. This is a classical picture, but this hyperostosis may not be there in all the cases. But the ballooning opacity is definitely pathognomonic in the CT scan. To diagnose a case of inverted papilloma, there may be bony expansion because inverted papilloma can expand the bone, can erode the bone, can expand the bony expansion. So the ballooning opacity with the bony expansion. In the bony expansion, where do you see? In the CT scan. So the CT scan is generally you can diagnose the inverted papilloma in the CT scan. If you have a diagnostic dilemma, which more often it occurs in case of inverted papilloma in our clinical practice, then actually you can go in for the MRI. The MRI in a given case, in a classical case, is very much pathognomonic, showing the what is called CCP pattern, is a convoluted cribriform pattern, wherein you have alternate bands of hypo and hyper waves. You can see here the alternate bands of hypo and hyper waves. They are starting here, they are going here, the hyper and hypo waves which can occur. So this is very, very pathognomonic. And when there is a loss of this pattern somewhere, if there is a loss of this pattern, then you have to suspect malignancy. Where these hyper and hypo waves are starting, you can see here, this is the starting point. So probably this is the site of origin. So in inverted papilloma, the MRI can give an idea of the CCP pattern, which is a pathognomonic, and where the CCP pattern is starting, that's the starting point of that is site of origin, wherein you have to remove the cuff of tissue, normal healthy tissue also, because to reduce the recurrence. And number three, it can go, it not only shows attachment and take care of in the surgery, but also whenever there is a loss of CCP pattern in the MRI, suspect some malignancy. In malignancy, this CCP pattern is lost. Now, coming to a very common situation, allergic fungal rhinosinusitis, wherein you can see the CT scan is a very pathognomonic, the heterogeneity. If you have heterogeneity, classical heterogeneity in the contrast CT scan, for a case of allergic fungal rhinosinusitis, it is pathognomonic, and you need not go for MRI. In case of diagnostic dilemma, as I said in my first slide, is you can go in for the MRI. The MRI very classically shows in allergic fungal rhinosinusitis as a hypointense or a signal void. The calcium and magnesium, calcium and manganese salts, they show signal void areas. So they do not show any signal. They just the hypointense, totally very severely hypointense or signal void. It is a pathognomonic of the allergic fungal rhinosinusitis to diagnose. Then coming to mucocele. The mucocele, the most important investigation, if you want to choose which is the better investigation, CT or MRI, CT is the investigation of choice. Because the CT scan shows a circumscribed opacity with a bony expansion and thinning at the periphery and with the calcification. So this shows in the contrast CT. The contrast CT shows a circumscribed opacity, either in the ethmoid or frontoethmoid area, with a bony expansion and thinning due to calcification. The MRI is variable. It has not much of diagnostic value. It is a variable. Why it is variable? Because depending upon the water content and protein content that is there in the mucosal cavity, so it is quite variable. It has not much role in the diagnosis. So CT scan is the gold standard for mucosal diagnosis. Then coming to CSF rhinorrhea, in the imaging modalities that are available in the right now for CSF rhinorrhea is the CT cystoscopy, the HRCT, and MR cystoscopy, and the nucleotide imaging, and gadolinium enhanced cystosonogram, the fluorescein dye test, and MRI. I just briefly go each and everything. As you can see here, the HRCT, high resolution CT scan, and MR cystoscopy, they are non-invasive. That means we don't have to inject any dye. The CT cystogram, you need to inject the dye, and rest all are invasive tests. So you need to inject the dye. So usually the CT cystogram shows CSF leak and it gives a positive report only when the CT scan is active. The CSF rhinorrhea is active when there is an active leak. The MR is also, MR cystogram is also, whenever there is a leak is active, it shows. Otherwise, you may not get a positive result. So the HRCT shows only the HRCT 0.5 millimeters, which can show some bony defect, either in the pediform or in the lateral valvular sphenoid sinus, etc. So whenever, even in the absence of active leak, the HRCT has got a definite role because it can actually show the bone defect. So this is the advantage of CT cystogram is it can show the dye very easily in a case of active leak. The leak is not active, it has no role. And similarly, MR cystogram, the HRCT will show a defect. So radionucleotide we are not doing. The gadolinium enhanced cystogram, the advantage is it stays, the dye stays in the CSF for almost 24 hours. So if you go for a contrast study to diagnose a CSF rhinorrhea, so one need to take films within 2 to 3 hours. Otherwise, the dye will actually absorbed by the arachnoid villi and it disappears. The gadolinium, it stays in the CSF compartment for more than 24 hours. So you can take n number of pictures and you can actually diagnose. And the gadolinium has got its own side effects like epilepsy and all. The fluorescein dye test, it is not approved by FDA, and even we are not doing in India, not much, only in conferences and workshops. Where you could not find a CSF, you can go in for fluorescein dye test. Then MRV is only in case of raised intracranial pressure. Where there is a raised intracranial pressure, high CSF flow, then you can go in for MRV, MR venogram, where there is a sagittal sinus thrombosis or thrombosis of the cerebral vessels. So going through all, I think the consultant practitioner will get confused. Which investigation is no choice? See, my choice will be initially anybody they want to prefer a non-invasive technique. If I have a CSF leak, I prefer non-invasive. So generally, we can go in for the HRCT or MR cystogram, which are non-invasive. So if not, some centers they prefer CT cystogram. So it depends on your protocol in your department, in your institute. But given a choice, my choice would be a non-invasive like HRCT and cystogram. If not, go for a CT cystogram. So other investigations we don't maintain. You don't do it wrong. Am I clear?
Yes, sir. Yes, sir.
Okay. Now, I'll go through some of my CSF leak cases where you can see this is a CT cystogram with a dye. You can see on the left side there is a leak with the ethmoid fovea. You can see the contrast flowing there. At the left fovea, you have a leak. And this is another case of mine which is operated almost 12 years ago. So this is a child of 9 years. You have the plain HRCT. Because this is our initial investigation. Plain HRCT is a case of left meningoencephalocele. So these cases, I think you can additional advantage of MRI is always there. You can actually see the MRI whether brain tissue is present or not present. So to diagnose meningoencephalocele, you can see the defect here. You can see defect here, and there is a meningoencephalocele. So the choice is meningoencephalocele, the HRCT as well as the MRI. Both can be done for various reasons. for more detail. MRI will give a soft tissue detail, and HRCT you have a bone defect. So this is the MR cystonogram. MR cystonogram, you can see the highly weighted T2 image. The highly weighted T2 image gives a positive signal. So which is a non-invasive technique, non-invasive, and the MRI will give straight away the CSF leak diagnosis in case where there is a leak is active. Then the MRI, CSF leak versus MRI. Do you go for CSF? All cases you go for CSF leak, MRI? Yes, I go for MRI. Not only the CT scan, HRCT, but I do MRI for all my cases, MRI, for a simple reason, because it gives not only diagnose the CSF leak, because it gives a T2 highly weighted signal in T2 in active leaks, but also it gives a raised ICP. If there is a raised intracranial pressure, the MRI gives a lot of information, like dilatation of the optic nerve sheath. You have a tortuosity of the optic nerve. You have slit-like ventricles. You have empty sella, hydrocephalus, low flattening, optic atrophy, and so on and so forth. So the advantage of the MRI over the CT scan. CT scan, of course, will do it as a primary investigator. The advantage is MRI diagnosis is CSF leak, so it gives a signs of raised ICP can be found out, and it rules out most important intracranial pathology like the tumors, space optical lesions. I show in one of my slides where you have a space optical lesion and CSF leak. Now, this is the highly weighted T2 image. This is a case of meningoencephalocele. There is a meningoencephalocele. In this case, we have gone straight away for MRI. And this child is a poor child, she cannot afford. So the one imaging modality they can afford. So we have done the MR. So we have done only MRI for a congenital meningoencephalocele. This is an 11-month-old child, 8 kg, weighing 8 kg. The encephalocele mass extending into vestibule, and the swelling is increased just by lifting the tip of the nose. You can see the meningoencephalocele mass. So such a huge mass, congenital mass, and for every cry there is some CSF leak. Active leak is there. Actually, this case has gone for neurosurgeon. The neurosurgeon said we are not going to operate such a small child because they obviously operate the external approach, most of them. So, in spite of there is active CSF leak, you refuse surgery, let the child grow. But that's not the real concept. But we're not going to agree. Even whenever there is active CSF leak, the child can go for meningitis anytime. So, we are operated. This case is being operated at the government UNT hospital, Koti. Almost 12 years back, the child is going to the high school right now. Then, a word about intrathecal fluorescein. The intrathecal fluorescein is useful in multiple leaks. Today's role of the intrathecal fluorescein, because intrathecal fluorescein not approved by FDA, it is associated with the fluorescein injection of fluorescein, and there is a chances of epilepsy as well and side effects. So still it is used in some centers for the obvious advantage of identifying the multiple leaks, because the intrathecal fluorescein is very highly sensitive. So it can give the signal in the dilution of 1 in 25 million. So the multiple leaks can be identified. If there is one person that the multiple leaks, it can be identified very easily by intrathecal fluorescein. And intraoperatively, when you have done the job of closing the CSF, you have done the repair of CSF. And for intraoperative checking, you can actually use this fluorescein. Post-operatively, intraoperatively, immediately after closure, you can actually check whether your job is complete or successful intraoperatively. Now, this is a case of a traumatic CSF. You can see there is a trauma here. The husband has hit with a rod over the head. You can see the fracture of the inner table of the frontal sinus, the outer table of the frontal sinus. The CSF is flowing. And there is a meningoencephalocele also. The meninges are being herniated into the frontal sinus, and with a double fracture of the antetable and posterior table, and the ideal imaging modality in the traumatic series of leaks is the CT scan. And this case, the impact of imaging so much that there is a fracture, the anterior table and posterior table, so this cannot be repaired the endoscopically. This is gone for external approach. Now, coming to imaging of the JNA, as everybody know that the choice investigation is the CT contrast. CT contrast is the choice investigation for JNA, for diagnosis of JNA. Then what is the role of MRI and the MR angio? The MR angio will give accurate assessment. MRI will give accurate assessment of the extension of the JNA in the skull base, in the various crevices of the skull base. And also it gives, whenever there is an intraorbital extension and intracranial extension, the MRI is indicated in the case of JNA. So it is extremely useful investigation in the case of JNA. Although CT contrast is the gold standard, the MRI should be done in these situations wherein there is intraorbital extension, intracranial extension, and also for accurate assessment and staging, the MRI is required, especially for involvement of pterygoid marrow. So the greater ring of the sphenoid, the basis sphenoid, the Bibidian canal. So these things are better assessed, especially the marrow. The pterygoid wedge marrow is one of the important sites of origin. The marrow bone cannot be assessed in the CT scan. The MR can assess. So digital subtraction angiography is to embolize the vessels and to know what are the feeding vessels. So this also has got very important. We used to do DSA a lot in the initial stages of our practice. So in the initial 15 years of my practice, we used to send all the cases of DNA for digital subtraction angiography to know the feeding vessels and block them with the gel foam and polyvinyl particles. So now the concept is being changed. Now we intraoperatively clip the vessels. Those 3D CT angio is again shows the 3D picture with the CT scan. This you do a CT scan with the injection of the dye and delineate all the vessels supplying the chain. So which vessel is going in which direction? Whether the IMAX branches, IMAX is coming from laterally or from behind or below, then you can actually assess in 3D CT angio. And this also can be assessed in MR angio also. Now, these are some of the pictures of my cases. As you can see, this is a plain CT. This is a JNA. You can see the widening of the sphenopalatine foramen area and extension into sphenoid sinus. You can see very clearly, it's a plain CT. Now, the contrast CT will give actually, it can delineate the dumbbell shape with tumor here, and you can actually see the hormonal mirror sign, the anterior bowing of the posterior wall and anterior sinus. So, very clear. Here, the contrast shows. And this again a contrast where there is extension into the, so this is the JNA. You can see there is a erosion of the septum here. So this is the nasal cavity. This is a sphenopalatine foramen area. This is a pterygomaxillary fissure. So this is a pterygopalatine fossa and this is lymphotemporal fossa extension. You see a typical dumbbell, the nasal cavity, the sphenopalatine foramen area. Yeah. Now, what is the role of, now we are coming to, what is the role of JNA, what is the role of MRI in the evaluation of JNA? It differentiates the tumor from the soft tissues, and in CT scan, even in contrast, the tumor may appear bigger. When you take MRI, actually it becomes a smaller size. Because there is soft tissues and retained secretions will actually show the tumor size differently and involvement in different areas. For example, the retained secretions of soft tissue involvement can clearly delineated in the MRI. The tumor that appears in the CT contrast may be bigger, but it can be smaller in the MRI. The accurate assessment of the staging. Intracranial extension, if there is a cavernous sinus involvement, orbital involvement, you have to go for MRI in case of JNA. And as I said, the medullary bone marrow involvement in the pterygoid wedge and the greater ring of sphenoid and basis sphenoid can be evaluated the MRI better than the CT scan. Now, this is the axial CT. Another important point that MRI can tell us in the T1 weighted images, you can see the multiple signal void areas. You can see the dark spots there. Can you see the dark spots there? Round spots.
Yes, sir.
So these dark spots are known as flow void areas. If you have in a JNA, this is a MRI T1 weighted image, wherein if you see more these flow void areas, that is the JNA is very, very vascular. If you have less flow void areas, you are dealing more with the fibrous tumor. If the flow void areas are many, then you are dealing with the more vascular tumor. So that a MRI T1 weighted can give such a vital information before operation. And you can actually assess whether you are going to deal with a very vascular tumor and your field is ready or not ready. Now, the T1 contrast is again a T1 contrast image. Here you can see the flow void areas. You can see the flow void dark spots, flow void areas, the signal void areas. Then this is we used to do a lot of embolizations in our early life of JNA management, wherein you can see this is a tumor blush, you can see here, and yeah. Able to see? I think slides are jumping. Are you able to come? Is the picture there? Hello?
Yes, sir. The
Yes,
picture is there.
yes, sir.
Yeah. Now, this is the embolization, pre-embolization and post-embolization. You can see tumor blush, the disappearance of tumor blush. And this is a digital X-ray. Digital X-ray taken soon after embolization. On the left-hand side, you can see the tumor blush, digital X-ray of the PNS. And on the right-hand side, you can see the disappearance of the tumor blush after embolization. So these pictures were my old pictures more than 15 years back. But now we are not doing any embolization for the obvious reasons, because our concepts have changed, our management of JNA have changed. Now, coming to invasive fungal sinusitis. The invasive fungal sinusitis, you have an acute invasive, you have a chronic invasive. Acute invasive is a very, very fulminant variety, wherein the rhizopus and bupa are responsible, and aspergillus is also responsible in about 80% of the cases. This is a very life-threatening condition. The chronic invasive, the other way, is a non-life-threatening, but still it has a dangerous situation. It can occur in diabetics, it can occur in non-diabetics, non-immune compromised also. Sometimes immune competent people will have this chronic invasive sinusitis, because I have come across at least half a dozen cases where a chronic invasive sinusitis the acute invasive but more or by and large the ideal situation. Now, acute invasive fungal sinusitis, CT scan. The CT scan shows the bone destruction, obviously. And you can see here, there is a proptosis. It is a diabetic, uncontrolled diabetes. And you see that there is a ethmoidal involvement here. And there is a bone destruction of the lamina. And it is going in, and there is a bone destruction of the lamina. And it is going intraorbitally. There is a proptosis. The CT scan will give bone destruction in case of acute invasive. Then what is the usefulness of MRI? The MRI gives very important and vital information in acute invasive as to whether there is involvement of the muscle, involvement of the soft tissues, involvement of the fat, that is a periantral fat, especially in the maxillary sinus, or involvement of meninges. This gives a very vital information. Based on this, I think we can easily diagnose the MRI. So in a given situation, what should we do? Acute invasive, as a primary modality, we can go for CT scan. And for added investigation, for more vital information, we can do MRI. And both are very good, and we are supposed to do both in my practice. So some people in new car era, some people used to go for only MRI, but that will give a lot of confusion. You need to have a bony anatomy first and then show the soft tissue anatomy next. Now, this is a mucormycosis. The classical picture in mucormycosis, the most important site and most common site is the maxillary sinus. Here you can see the right maxillary sinus. You can see the right arrow on the left-hand side is a CT scan, and this is a MRI. Left-hand side, the CT scan, right-hand side, the MRI. You can see the CT scan showing there is intra-orbital extension through a bone defect at the orbital fluid. And you can see the same case, if you take an MRI, you see here, there is a signal void area. There is a hypo intense shadow. So that shows the mucor. So in a hyper intense area will show hypo intense in MRI in the orbit. Now coming to chronic invasive. This can occur in immune compromised or immune competent host. He is a man whom I operated almost 14 years ago. Still he comes for follow-up, and you can see this is a tumor-like situation. I removed it from the maxillary sinus. So look at his CT scan. This is a CT scan wherein you can see a mass in the nose here, and which is going into the orbit. Right? It's a tumor-like. So I had no clue as to what it could be because he's an immune competent host. So the CT scan showed the hyper attenuated soft tissue mass-like lesion with a bone destruction. This is a classical picture in a chronic invasive sinusitis. Now the same man, if you take MR, you see here there is a signal void. There is a low intensity signal on T1 and T2 weighted image. The T1, T2 weighted image will give a low signal or signal void in T1 as well as T2 weight. Both T1 and T2 weighted images, there is a low intensity or signal void. This is a pathognomonic of chronic invasive sinusitis. Now we'll go for another picture where there is a frontal sinus involvement. You can see the CT scan on the left-hand side, MRI, there is a signal void. In a case of chronic invasive, which is a slow indolent course, but it is a slowly progressive, slowly destructive, unlike acute invasive, which is a fulminant. Now, this is a classical picture. There is the hyper attenuation, and then there is a signal void, a low intensity signal. Now, coming to olfactory neuroblastoma. The olfactory neuroblastoma CT scan does not have a specific pattern. If you take a CT scan, you see homogeneous soft tissue mass, and you cannot say with certainty that the CT scan can give that it is a definite case of olfactory neuroblastoma. There is no way you can diagnose in the CT scan because there are so many tumors which can give homogeneous intensity signal on the nasal wall. So a CT picture shows like this. These are contrast pictures on the left-hand side and plain picture on the right-hand side. Now, if you go for a MRI of the same olfactory neuroblastoma, you see the T1 weighted image will give intermediate, the T1 weighted images, the T2 weighted images sequences are hyperintense. The T1 weighted images are intermediate to hyperintense in T1 and T2 weighted image. So actually this can occur even in any malignancy. So radiologically, even MRI also cannot give a positive signal that we are treating with the CT scan will obviously show a bone. This is a CT scan. It shows the bone destruction. Destruction of the bone destruction is a maxillary cancer. And you can see the destruction of the anterior wall, destruction of the posterior wall, lateral wall, all the walls are being destroyed. And if you take MRI, then you see the MRI will show hyperintense. The T2 weighted image usually hyperintense or heterogeneous intensity. Again, in squamous cell carcinoma, depending upon the bone destruction will actually decide, and their extensions will decide whether we are dealing with a case of the squamous cell carcinoma or not. But there is no classical picture that can be drawn in the CT scan as well as MRI. So the CT scan and MRI both have to be taken in a case suspected case of malignancy. The CT scan shows the bone destruction, the soft tissue invasion, and soft tissue involvement, especially the dura, the cavernous sinus, the intracranial extension can be shown in the MRI. Squamous cell carcinoma again, this is a CT scan picture above, and these are MRI pictures. The CT scan contrast, these are contrast CT scan films, where you can see the heterogeneous intensity. The MRI is a variable picture. You can have a mixed heterogeneous as well as endogenous depending upon what type of cancer, what type of the cells, malignant cells we are dealing with, and what's the maturity of these cancer cells. Then coming to sarcoma, the sarcoma of the nasal cavity, MRI, you can see here, this is a CT scan where you see the hyperintense mass, and this is again the MRI picture. Synovial sarcoma, the contrast enhanced CT scan, this is a contrast enhanced CT scan, you can see the heterogeneously enhancing mass. Synovial sarcoma gives heterogeneously enhancing. The contrast will be taken up very much, and there is a heterogeneously enhancing depending upon the cell types. Then if you take MRI of the same synovial sarcoma, then it can reveal the soft tissues, which are again a mixed pattern depending upon what type of cancer you are dealing with. But by and large, they reveal the enhancing soft tissue masses. Now, the fibro-osseous lesions. This patient actually came from Tirupati, and you can see this foramen rotundum. This is a fibrous dysplasia of the sphenoid sinus, and her main complaint is a headache, severe headache, deep-seated severe headache. Then we counsel the patient, but you cannot take away completely. Here we can damage the mandibular nerve, the V2, and we can actually cause CSF leak if we drill out more here. So I said we can remove 90% of the tumor with the drilling. You can see the pterygoid plates also being involved here. So the fibrous osseous dysplasia, the choice investigation is the CT scan for obvious reasons, because it's a bone, the fibrous tissue mass. There is no role for MRI in these cases. If you have a CT scan classical picture like this, the fibrous dysplasia, then there is no role for MRI. You can actually stop short with the CT scan. So this patient, again, she is coming for follow-up. Her headache is only partially relieved. And this is the fibrous dysplasia of the ethmoid. CT scan is the gold standard and choice investigation. No role for MRI. Now, this is osteoma. Obvious reasons, bony architecture, CT scan. No MRI. Thank you very much.
Thank you very much, sir, Dr. Venkataram Reddy Garu, for your elaborate and wonderful insight on the radiology of paranasal sinuses for a beginner and for a practicing and a senior consultant also. We are very happy to have you with us, and we are very thankful to the organizers Sun Pharma for their generous contribution for medical education.
Hello.
Thank you, Dr. Kameshwar Rao. Any questions?
Sir, Kameshwar sir.
Yeah, tell me.
Sir, you can check the questions link, sir. Questions.
Yeah, just 1 minute.
Sir, before they see the questions, I just want to thank Dr. Venkataram Reddy sir for a wonderful collection that he has got over the period of years, all the clinical examples and so many CTs and MRIs. And sir, just I wanted to have one question. The supraorbital situation, supraorbital cell you shown in your presentation.
Yes.
So how to in that when the supraorbital cell is very big, like what you have shown?
Yeah. See, the
So-
supraorbital situation, you cannot diagnose in one modality of CT scan. You need to have the multiplanar CT. That is number one. Number two, whenever there is a supraorbital cell, it mimics as the frontal sinus.
Yes, yes,
In
yes.
coronal cuts, it mimics as the frontal sinus. You presume that is the frontal sinus only.
Yes.
If you take axial cuts, there is a differentiation, there is a walling, there is a partition between the supraorbital cell as well as definite partition between the supraorbital cell and frontal sinus. And when supraorbital cell is there is a huge supraorbital recess. And there the skull base tend to go more posteriorly and back because it expands. So the anterethmal artery tend to be more posterior.
Yes, sir.
Dr. Venkatam Reddy garu,
Yes, sir.
there is a question from one Dr. Fanibhushan.
Yeah, with my PG.
How to operate on the hypoplastic maxillary sinus?
Yeah. Hypoplastic maxillary sinus, as I said, I think I go back. Just a minute if I see it, just a minute to explain. So this is very common situation, sir. We get a lot of cases like this. Hypoplastic maxillary sinus, first you have to diagnose in the CT scan. How you are able to diagnose? You draw a line from the medial orbital wall. You draw a line, imagine line from medial orbital wall. If the medial wall of the maxillary sinus is much lateral to the medial orbital wall line, then you are dealing with a case of some sort of hypoplastic maxillary sinus, if not classical. In a case of classical hypoplastic maxillary sinus, it assumes a shape of oval shape. And the normally the maxillary sinus pneumatization go up to the floor of the nasal cavity. But whenever there is a hypoplastic maxillary sinus, the pneumatization does not extend to the floor of the floor of the nasal cavity. It stops high. And it is small. So it has more proximity. The uncinate is almost attached to the medial orbital wall. So these kind of situations, first, you cannot operate with a 0 degree. The uncinectomy infantilotomy cannot be done with a 0 degree. You need to have a 70 degree telescope ideally and look at the lateral nasal wall in the uncinate area all the time and take a ball probe, which is non-traumatic, least traumatic, and try to identify the uncinate going back into the ethmoidal infundibulum and come anteriorly and try to do a millimeter dissection. You are not afford to go posterior dissection. You have to come in the infundibulum, you insinuate a ball probe. Ball probe is the key. Because sometimes in hypoplastic maxillary sinus, you cannot use the backbiting forceps also. You can use with a lot of experience, and you need to have a very small backbiters. But backbiters also have different sizes. Smallest size of backbiter would be safe, and after identifying the ball probe.
Now, orbital penetration is more common in this type of.
Yes. So many a time, even I entered the orbit sometimes.
Oh.
So in our initial days. So ball probe and smallest size of the oscillum biting are key in these cases.
So no more questions, sir, from the audience. I think they are very much through the lecture. So thank you very much, sir. Kumar Chaudhary garu.
Any comments from you? No questions. Any comments?
A very good lecture, sir, because this is a for the beginners and for the consultants also, and the skull base point of view also you have elaborated very well, and where to the MRI is superior to CT scan, that's also you have elaborated. So all the points you have covered, sir. Very good.
Thank you, Commissioner.
Hello?
Jayaprakash, anything to add?
No, sir. That the only this one, the supraorbital cell, there was a doubt that is clarified, and most of the anatomical variants and in relation to the important structures were shown very well, and most of the common conditions to rare conditions were also shown both in CT and MRI, and it's really a good eye opener. It's a very good lecture, and I thank Dr. Venkatramreddy sir for taking his important time and giving a very good lecture for us. And we'll be very thankful to you, sir, and many more to come in the days to come. Thank you very much. And Praveen, you want to say vote of thanks?
So before that, I think special thanks to Dr. Jayaprakash Reddy for taking initiative, calling me, and Sun Pharma for actually gathering all of us. Thank you
I
very
think
much.
Dr. Appara is here, sir. You want to add anything, sir? Dr. SKE? Dr. SKE, sir.
I think he's logged on, but he's not.
I think he's gone for dinner, I think. Okay, no problem.
Doing some
Praveen?
case. Praveen, I think he left. He asked me to say the vote of thanks, sir. So I think we'll close.
Okay, sir. Thank you very much.
Thank you very much.
Thank you, sir. Thank you.
Right.
Thank you.
Thank you.